my pill, they stick it under their tongue, and the person feels better almost immediately, and the heart attack is prevented. All right, well, let's see why that happens. So the problem with nitroglycerin, so we go to the next slide, and this is nitroglycerin, and this is nitroprusside. We are going to mention nitroprusside. The problem with all of these drugs is they undergo first-pass metabolism. You cannot really give them orally and get therapeutic concentrations because they're removed by the liver too rapidly. So they have an extremely short half-life. So what has happened is the pharmaceutical companies have come up with alternative routes of administration so they can bypass the first-pass metabolism. So in people, they'll take that little tablet and they'll stick it under their tongue, and so it will be transmucosally absorbed. Another thing that they have actually now are nasal sprays down here. It's hard for us to use those in animals. What we'll use in animals is the ointment, and so that's shown right here. So to administer nitroglycerin, generally in dogs, and cats, we'll put it right on their abdomen because that's the place of the body that has the least amount of hair. In cats, we really should put it in the inside of the ear. But that's all about because of this first-pass metabolism. We're trying to get effective concentrations there. So let's talk, so that's nitroglycerin. Over here, and that's nitroglycerin down here, and I actually want you to use nitroglycerin as the model drug. I've got it in parentheses because at Auburn, in our critical care environment, we use nitroprusside more, and I want them to know that. But I think in practice, you're much more likely going to use nitroglycerin, so we'll have nitroglycerin as our model drug. So its indication will be in an emergency situation. You have an animal with right-sided heart failure. It's about to die because of that. And maybe left-sided heart failure as well. But you need to get that preload out of the heart. And so we'll use nitroglycerin for an emergency situation to remove that blood from the heart. We have it pull in the vasculature, splanchnic vasculature. You're buying time. That's all you're doing. You've got to get those diuretics on board, you've got to get your other drugs on board, because eventually this is not going to help the animal anymore. Now, let me just say a word about nitroprusside. So nitroprusside is used, and I'm not sure if it's used in your critical care environment. The problem with nitroprusside is it targets both the arterial side and the venous side, and there is great risk to kill your patient because of hypertension. So to use this drug appropriately, nitroprusside, you have to have arterial catheters in. You have to be able to monitor blood pressure very, very rapidly and discreetly. And the way that you'll use nitroprusside is you'll have it on a drip, and you'll turn the drip up if the blood pressure is too high, and you'll turn the drip down if the blood pressure is too low. That short half-life allows you to do that. You're not going to be able to do that in most practices because you won't have that, those instruments to help you do that. So that's why I want you to use, have nitroglycerin on board. So we'll talk about nitroglycerin, and we will use it as a preload reducer by causing venous dilation in emergency situations where we want to shunt the blood away from the heart for a period of time. Okay, any questions about nitroglycerin? I think that's our last slide on nitroglycerin. All right, so the vasoconstrictors you already know. The biggest vasoconstrictor that we would use is probably epinephrine, and the most common place you're probably going to use it is here with lidocaine. Why would you use it with lidocaine?
Vasodilation? No,
vasoconstriction. Why would we want to vasoconstrict?
To keep it in the area.
To keep it in the area. We'll use it, for example, lameness exams. Or how many of you have gone to the dentist? Like, who hasn't? How many of you gotten lidocaine? Okay, we call it Novocaine. Have you ever gotten your heart rate up? It's not because you're in the dentist chair. My heart rate's already up. I get my hit of Novocaine, and I'm like, oh, really? My heart rate goes sky high. And I've asked them to use less epinephrine in my lidocaine, but they do it so it'll stay here. Another example would be in people that have hemorrhage, nasal hemorrhage. They'll put epinephrine on tampons and stick them up the nose to stop the nasal hemorrhage if you can't get it to stop. And we've seen that in horses as well. Now the other one here is norepinephrine. We will use norepinephrine in patients that are hypotensive on the surgery table when we can't get them to respond, but that's probably not the preferred drug. Dopamine would probably be the preferred drug, but it depends upon the anesthesiologist. They'll use it to maintain blood pressure in states of hypotension on the surgical table. Why won't we use epinephrine to do that?
Because it's not as selective.
It's not selective, and what's it gonna do to our patient's heart? Increase it. So here, and I tell my students this at Tuskegee and at Auburn every single year. We will see this when we get to positive inotropes. Epinephrine is not a drug to use for positive inotropic support or vasoconstrictive support. You will kill your patient. The only time to use epinephrine is with imminent cardiac standstill, where the heart is stopping. I do not want to see you reach for that drug to support your patient's heart or to support your patient's vasculature if the patient is not in cardiac standstill or is about to die from cardiac standstill. You know, very bad ventricular fibrillation may be benefiting from epinephrine, okay? All right. Okay, so any questions about that? Because what I'd like to do is take the last 20 minutes to at least start with antiarrhythmics. Can we do that? Okay, and I may just spend 10 minutes to do this so that we can have a little bit of downtime. We can have a little bit of extra time. Do you have your antiarrhythmics?
Oh, no, just.
I'll give you a couple seconds to pull it up. I sent all of your positive inotropes. I just wasn't gonna trust that we don't have them anymore, so I sent you everything except glucocorticoids, so you have all those. Okay? Now, the other thing I'm gonna try and get Dr. Word to set up is flashcards. Last year we had flashcards, Excel files, where you can make flashcards for all of these, and we're working with, hopefully with Dr. Word too. He has them, and hopefully he can just post them from last year. So, and where's our class president again? I'm sorry, and I've forgotten your name. Sheridan, okay. So we're working, and hopefully we'll have those things posted. Let's try and get that done today if we can. And then we will have a help session Thursday. And if we need to make it a little bit long, because we have opioids, we have anticonvulsants, and we have cardiovascular drugs, right? So we need to make it a little bit long. I can be prepared to stay a little bit longer, okay? Just come with your questions, all right? Okay. And then the other thing that we're going to work on is trying to come up with a time that we can talk about calculations. So let me ask you a question. In previous years, we've had exercises where you got extra credit doing calculations. I can try and institute that, where just the problem is we're more than halfway through the semester. And you know, normally there have been 6 sets, and each one's gotten progressively harder. And so I just don't think we can get them all in before the end of the semester. You'd have to do 1 a week. And I just don't think with exams coming up and finals coming up that that's probably a good thing to do. You can talk about it among yourselves if you want, but I just think it's a little bit late. Pardon?
Would they be extra credit or would they be an assignment?
They would be an assignment, but maybe what we can do is, I would have to talk to Dr. Joe, we could potentially talk about that. But they're an assignment, but they tend to be so easy that they end up being, you know, if you just pay attention to them, you make, or at least previous years, they've gotten all the points. So it's been like getting 50 out of 50 points added to your grade. But we could potentially talk about them being extra credit, and that would be one way to potentially handle it. So if we did that, then I'd want to jump to the harder ones, just because we don't have, and they're not that terribly hard, but they get a little bit harder with each one. Or else I'd make the easier ones not many points, so that you could jump right to the, all right, let me see what we've got Dr. Judd's coordinating, so we probably have to work with him and Dr. Ward too. All right, so let's see what we can do about that. All right. Okay, so has everybody got their antiarrhythmic slides up? Okay, you've been troopers. This is a lot of stuff today. All right. So here's the deal with understanding antiarrhythmics. To me, it finally made sense. And boy, I'll tell you what, there is so much we don't know about antiarrhythmics. But it made sense when I finally went back and studied the action potential and the ions responsible for the action potential, and especially the ions responsible for each phase of the action potential. And what really made the difference for me was understanding that all that differed if the cell was a pacemaker versus a non-pacemaker cell. And once I understood that, then I began to understand why diltiazem, for example, is ineffective for ventricular arrhythmias. So I'm gonna walk you through that process so that hopefully we can make sense out of the antiarrhythmic drugs. So, and this is where I think you need to go back and hopefully read before next Monday. So what I've shown you here are two cells. This is the pacemaker cell, and this is the non-pacemaker cell. The non-pacemaker cell, what is the job of the non-pacemaker cell?
Progressive.
It is to contract. Why? What's its job? Where's the primary pacemaker cell, non-pacemaker cell located?
AV node?
Myocytes.
Where?
Myocytes.
All right, so where are the primary myocytes that are non-pacemaker related located? The ventricles, that's right. The ventricles are the workhorse. Those are the guys that pump the blood. We'll have myocytes in the atrium and they'll contract, but they really don't do anything. They don't really empty the atria. The atria empty because the valves open and the blood follows gravity. So the non-pacemaker cells, they're all about contracting. So what are they going to need to be able to contract?
Calcium.
Calcium, that's right. So the first thing that we need to understand about non-pacemaker cells is well, two things. First of all, they got to do things rapidly. They got to go really, really fast. And so if you look at their upswing of phase one, their ability to reach action potential, they do it fast. And they do it fast because sodium is the primary ion responsible for that. Is that making sense? Now, the other thing that they've got to do is they've got to get calcium in the cell. And that's what this phase 2 plateau is all about. It is due to calcium influxing and calcium moving back and forth, so it's flattening the rate of depolarization. It's flattening how fast things become negative. And that's a critically important part of that cell's action potential, because that's where the calcium that's necessary to release intracellular calcium comes from. If you block that phase 2, then the calcium inside the cell is not going to be released as effectively, and we're not going to see contraction. So right away, anything that impacts phase 2 is going to potentially do what to my heart? It's going to decrease contractility. And that may not be a problem in the normal heart, but what heart is that going to be a problem in? The failing heart, that's exactly right. So what kind of drugs do you think are going to negatively impact that phase 2? How about calcium channel blockers? Does it make sense that calcium channel blockers we're going to have to be careful with? And then I heard it down here, beta blockers, right? We know beta blockers decrease contractility because we know beta adrenergic receptors increase contractility, right? Okay, but notice what doesn't happen here. Once we repolarize, and we do repolarize, and we get way down here, we've got a high resting membrane potential, but then it's flat. So let's come back to the pacemaker cell. What's the pacemaker's job?
To initiate the...
That's right, to initiate the heart, the whole impulse that ultimately causes excitation, contraction, coupling, right? So what's a pacemaker cell got to be able to do?
Maintain itself.
Let's call it maintaining itself. What has it got to be able to automatically do?
Initiate.
To depolarize, to initiate the process. And so if we look at phase 4 of the pacemaker cell, we compare it to the non-pacemaker cell, what's different here?
It's about to start.
It's going up. It's slowly increasing, right? And it will continue to increase until it reaches the threshold that causes an action potential. So it is capable of spontaneous depolarization. Is that making sense? Now, what does it not need to do really well?
Contract.
It doesn't need to contract. So what's it missing?
So
It's missing that phase 2. Okay. All right, so now let's come over here to the upswing. So because it doesn't have to do things really fast, then the upswing, first of all, starts at a higher, let's call it a lower resting membrane potential. Remember, a very negative resting membrane potential is higher. So it's a little bit confusing. We're going to talk about hyper and hypopolarization. What I'll always try and do is say it is less negative. The more negative resting membrane potential is actually an increased resting membrane potential. So we're going to try and avoid saying things like that because we don't want to get confused. So the pacemaker cell starts at a less negative resting membrane potential. And it doesn't have to go as high, it doesn't take as long, because it does need to be able to be capable of the spontaneous depolarization. So when we talk about phase 0 of pacemaker cells, those are slow channels. And in contrast to the non-pacemaker cells, those are calcium ions. So when we look at the differences in the action potential, especially phase 0, the calcium ion is primarily responsible for phase 0 of the pacemaker cell. Is that making sense? Versus the non-pacemaker cell, it's going to be sodium. Now, there's a little bit of calcium here in the non-pacemaker cell, and there's a little bit of sodium here in the pacemaker cell. Do you see that? But not much. So, if I'm going to use a sodium channel blocker, is it more likely going to be effective for ventricular or atrial? Supraventricular or ventricular? Ventricular, that's right. So we'll see that procainamide, it will have some supraventricular effects, but it's going to be more effective for ventricular arrhythmias because it targets sodium. If I have a calcium channel blocker, is it going to be more effective for supraventricular or ventricular arrhythmias? Supra, and especially those associated with the SA node, right? Because remember, the atrial fibers do have sodium. The atrial fibers do have this upswing associated with sodium. Is that making sense? So we will see sodium channel blockers have some efficacy in supraventricular arrhythmias, but not nearly as much as the calcium channel blockers. Is that making sense? Okay. Well, that's great, but this is all normal tissue, right? Now let's just think here. What if, let me go forward here. So what's one of the, let me back up here. So let's envision, do you remember in your histology, and in fact, let me do this. I've still got 5 minutes. Let me go to this slide that we're going to be using here in just a little bit. Right here. Okay, you remember in histology what your fibers, your myocardial fibers look like? What's different about myocardial fibers compared to any other muscle? Branch. Why do they branch? Did you say more surface area?
Well, more ability to transfer the action.
All right, so why do we want myocardial fibers more than any other muscle to have this ability to transfer the signal in different directions? Because the heart's got to contract. Those ventricles have to contract, and we need the signal to go down, and then we need to go up, and then we need that to happen in a coordinated fashion. Is that making sense? So what mechanism does the body have, the heart have to protect itself if this signal that is able to go in all these different directions comes too early? What mechanism does it have to protect itself? Well, the clue was here. The clue was right here. What do we call that? We have refractory periods. We have periods during which the heart is not, the myocardial cell is not receptive to signals. Now, we have the absolute refractory period where it ain't nothing going to tell it to shoot. And then we have a relative refractory period where it takes a little bit more of a signal to get it to shoot. And together we call those the effective refractory period. Is that making sense? What ion is responsible for that period? And it's primarily phase 3. Is that making sense? What ion is the major role player here? Potassium, right? So potassium, and we're changing the efflux. So potassium efflux is not occurring anymore. Potassium is being retained, so that resting membrane potential is becoming negative again. Is that making sense? All right. So here's what's going to drive you just crazy a little bit. So what is responsible for phase 4, for the spontaneous depolarization in cells capable of automaticity? What ion's responsible for that?
Calcium.
Not so much sodium, what's down there? Potassium. Now, what the heck? I mean, potassium was causing it to go down, and now potassium is causing it to go up. You remember Mowgli the cat? The black and white cat that became gray in color? Here we are. So, there are about probably at least 9 different types of potassium channels. And some of them are responsible for efflux, and some of them are responsible for influx. And it turns out way down here, at the very bottom of this resting membrane potential, there are a special set of potassium channels that are responsible for starting this process that tend to be targeted by our potassium channel blockers. So what I'm going to tell you is, if we have a drug, if we want to, so does it make sense? Regardless of the cell type, if we prolong that effective refractory period, then we are likely to decrease the risk of arrhythmias. Does that make sense? Okay, all right. What kind of drug are we going to target for that? What kind of channel blocker? Potassium. Yep. So our potassium channel blockers, understanding that they target different types of potassium channels, are going to be able to influence phase 3 as well as phase 4. And because of that, are they going to be more useful for supra or ventricular arrhythmias?
Ventricular.
I'm not happy yet. Both. There we go. They're going to be more effective for both, as a general rule. If we target potassium channels, they can be useful for both. But they are more effective for ventricular. You are right. They are more effective for ventricular. That was a good answer. Now, having said that, this is all the normal heart. What happens when we cause inflammation or hypoxia? What happens to these potentials? What happens to these action potentials?
Yeah.
They're all out of whack, right? So everything that we've said so far is for the normal heart, but we've got to remind ourselves that we are treating the abnormal heart. And so because of that, we have to be a little bit careful